Thank you for joining us, Dr. Tamara Rubin. Dr. Rubin completed medical school at University of Toronto, a general paediatric residency at University of Alberta, allergy and immunology training at University of Manitoba, and she did a fellowship in primary immunodeficiency at Cincinnati Children's Hospital Medical Center. Her primary clinical and research interests involve pediatric primary immunodeficiencies, and she is currently active in projects including the development of a Canadian National Inborn Errors of Immunity Patient Registry and gene editing for CD3 Delta Scare. She is excited about emerging diagnostic and treatment tools in the field and is hopeful for a bright and healthy future for all children and adults with primary immunodeficiency in Canada. Thank you so much for joining us today.
Perfect. Okay, thanks everyone. Thanks to Immunity Canada for the invitation and to the organizers. It's really great to speak with everyone today. Okay, so my objectives for today are to describe the diagnostic pathway for primary immune deficiency or inborn errors of immunity, which is our new terminology, as you've already heard. Give you a broad overview of the range of treatments that we have for inborn errors of immunity. And then I want to delve in a little bit to some of the research that's happening in Manitoba and across Canada, including describing the development of the registry, which is coming soon to Manitoba. So, as you know, inborn errors of immunity are kind of a broad term to describe many different conditions with many different features. And over time, more and more unique inborn errors of immunity have been described and then diagnosed. So in the 1980s, we only knew of one genetic primary immune deficiency, X-linked gamma globulinemia, and now in the 2024, there are close to 500 unique genetic disorders that fall into the category of inborn error of immunity. So when people want to know, like, what is an IEI? What is an inborn error of immunity? It's really hard to give a definition or an answer because there are so many different types. How severe are inborn errors of immunity? Well, the severity can be incredibly variable. Some people who have an inborn error of immunity may be asymptomatic. They may not even realize or know that they have weaknesses or differences in parts of their immune system. Some patients are only mildly symptomatic, and many of these are not even ever diagnosed in their whole life. They may just be suffering with symptoms. Some individuals are very symptomatic, and they may or may not be diagnosed. And then there are individuals who are severely affected. Often, although not always, these patients are identified as having an inborn error of immunity. And then, of course, there's the tip of the iceberg, individuals with life-threatening immune deficiencies. And they do tend to be identified. And an example of this would be severe combined immune deficiency, or SCID. Some of you may recognize the picture up there. That is David Vetter, also known as Bubble Boy, who was born with severe combined immune deficiency and lived his entire life inside a protective bubble because he was susceptible to pretty much any and all infections. He actually had a brother who passed away from SCID, which is why the parents knew that he needed to be protected. And he underwent stem cell transplantation in the very early days of stem cell transplantation. And unfortunately, he didn't survive. But now individuals with SCID can be identified, treated early, and lead full, healthy, productive lives. Okay, so when do inborn errors of immunity present? So just like that really wide range of severity of symptoms, there's also a really wide range of when patients get diagnosed for the first time. Some individuals get diagnosed right at newborn or infancy period. They come to my clinic for a variety of reasons. They can get diagnosed as a young child, sometimes in adolescence, and sometimes as adults for the first time. In general, the individuals who present with symptoms in infancy or young childhood, they're more likely to have severe forms of inborn error of immunity. And if they don't get picked up and treated, they may not survive. And often those who are presenting or diagnosed in that early period, they may require more invasive treatments like a hematopoietic stem cell transplant. So you can kind of see this correlation between age at diagnosis and severity of symptoms. And that's not to say that adults cannot have severe presentations, but simply that when we pick up an individual with severe combined immune deficiency as an infant, they may be extremely sick if they're not treated, and they would not survive past the first year or two of life without a definitive treatment. Okay, so I'm sorry to anyone listening from Saskatchewan. This is a little bit biased towards the knowledge that I have about Manitoba, but people ask, how common are severe immune deficiencies in Manitoba? Well, I told you previously there are about 500 unique inborn errors of immunity, but when you think about each one of these individually, they're rare. But some of the more common immune deficiencies, like selective IgA deficiency, not having the IgA antibody, we see that in about 1 in 300 individuals. When we talk about inborn errors of immunity, where someone might need something like immune globulin replacement, IVIG or SCID, that's about 1 in 2,000 individuals. Classically, when we look at data from the United States, how common is SCID or severe combined immune deficiency? The number we get is 1 in 60,000 live births. We've been screening for SCID in Manitoba for about 4 years now, and our rate so far is about 1 in 10,000. So if you compare that to the United States, it's significantly higher in Manitoba because of our unique populations. And some other studies, we predicted before we implemented newborn screening, the rate would be about 1 in 15,000. Some very rare but very severe immune deficiencies that we know exist in our population. For example, in northern Manitoba, there's a condition called IKBKB deficiency. We know that 1 in 700 people carry this gene. It's an autosomal recessive condition, meaning you have to have 2 carriers having a child to have someone affected. 1 in 13 carrier rate, which means that 1 in 700 people in certain communities in northern Manitoba would be affected with IKBKB deficiency, which is incredibly high for a rare and severe disorder. Okay, so it's not that common that primary immune deficiency or inborn errors of immunity makes it to the CDC, but this was actually an article published in 2022 in the CDC, and the title was "Study Identifies Gene Variant in Inuit Causing More Severe Reactions to Infection." And basically, they reported on a number of individuals of Inuit background who were getting severely ill from viruses like influenza, for example, becoming critically ill. And they identified a gene that's probably quite common within that population that is responsible for that susceptibility. And as a result, we, as part of a national working group, have been looking at the rate of this particular rare gene variant within that population, and there may be implications to finding out these individuals before they get sick in terms of how we can protect them in infancy and childhood from getting severely sick. So we're learning more and more about genetic reasons why some people are really susceptible to severe infections and what we can do to prevent them. Okay, so now I'm going to turn around and talk about the diagnostic pathway. So how do we make the diagnosis of inborn errors of immunity in infants and children? Well, there's 4 main ways that this happens. The first is through newborn screening. The next is through family history, as these are genetic conditions. The next is clinical suspicion, so someone coming to you with symptoms. And the last one is kind of an incidental. Someone had tests or investigations for other reasons, and the blood work suggested that there might be an immune system issue. So newborn screening. So in Manitoba, we've been screening for severe combined immune deficiency, or SCID, since September 2020. And across Canada, aside from Newfoundland and Labrador, every single part of Canada is screening for SCID. Some places like Ontario have been screening since 2013. Basically, when a baby is born, unless you opt out, every baby gets a little heel poke. They take a sample of the blood onto a piece of cardboard called a Guthrie card, and then they do testing on that card to see if they are at risk for possibly having SCID. When they screen positive, they come to the immune deficiency clinic and we do some further evaluations. And this way, we're able to identify and offer treatment right away before these individuals get sick. Oops. The next way that we can identify an individual with an inborn error of immunity is because of family history. These are by and large genetic conditions, although we often don't know the gene. So if there's a family history of a specific genetic condition, we can test the child for the familial condition. If parents know that they're carriers for a condition, we can even test the mom while she's pregnant. And then we may recognize that there might be a pattern of inheritance within a family, like every generation has this condition, or every other generation has this condition. And through that way, we can screen children to see if they might be affected. Okay, and then the next way, probably the most common by and large, is clinical suspicion. So the doctor, the nurse, the patient themselves suspects that something might be wrong. They're getting frequently sick, they're getting autoimmune conditions, they're getting things that signal that there's something imbalanced or off with their immune system. And then they come to an immunologist or another doctor who then does some tests to identify the immune deficiency. And of course, we all know that for individuals with inborn errors of immunity or primary immune deficiency, sometimes there can be a very long lag between when they first start having symptoms and when they finally get diagnosed, because it takes someone taking a very careful history, hearing all the symptoms, doing the right tests to really make that diagnosis. Okay, and so there have been some awareness campaigns about, primarily targeted at primary care providers like physicians, nurses, nurse practitioners, to be more aware of the possibility that their patient could have an inborn error of immunity. So if you're interested, you can scan the QR code. But if someone presents with unusual infections or unusual complications from an infection, autoimmune manifestations, big lymph nodes, or an enlarged liver or spleen, sores that don't heal, weight loss that's unexplained, or fevers without explanation, those are some indications that someone needs further evaluation for inborn error of immunity. So this is also a poster from the Immune Deficiency Foundation. Again, something that family doctors can put up in their waiting rooms, but really pointing out that there are so many different types of inborn errors of immunity. There's a real range of severity, a real range in when patients can initially present. And so we really need to consider this diagnosis and think about it when individuals present with the right constellation of symptoms and signs. We also know, again, that there's often such a long lag for patients to get the diagnosis, especially for the moderate immune deficiencies where they're not, showing severe symptoms right at birth. On average, patients are waiting 10 to 15 years to get a diagnosis. Okay, and a lot of patients are thought to be undiagnosed. So up to 70% of individuals who actually have primary immune deficiency or inborn errors of immunity remain undiagnosed. Okay, and then I mentioned, the last way where patients might get diagnosed, maybe they had screening tests because of, some chronic symptoms affecting other organs, maybe chronic diarrhea or chronic cough, asthma that was hard to treat. They get some screening tests and then someone recognizes actually this is a sign of immune deficiency. Okay, so regardless of the different ways that patients might get picked up, once someone gets a diagnosis, the next step is to do evaluations of their immune system. And that might involve blood tests, so lab evaluations, looking at the immune system number and components of the immune system, how it functions. Maybe they'll get vaccines to see how they respond to them. And then oftentimes genetic evaluations, which might be targeted to a specific suspected diagnosis, or maybe more broad, looking at all different genes that all different genes in someone's body. And that might involve testing just the individual or the individual as well as their patients. I just want to point out a shift in how we look at genetic testing. So it used to be that we do a lot of functional lab tests, and then depending on those lab tests, just kind of give treatment. Now, pretty much anyone with an inborn error of immunity or primary immune deficiency, we at least consider genetic testing. And in children, we actually do genetic testing very early on, pretty much for all of our patients. We used to do lab to try to find an answer, and then eventually, we're like, okay, we're pulling the trigger, we're doing genetics. Now we do some labs. When there's a high degree of suspicion, we go right to genetics, and that can be a very powerful tool for a variety of reasons. One is we can actually often direct our therapy. We may be able to give a very targeted medical treatment rather than just something broad. We may be able to give a patient and their family a more precise prognosis. How are things going to change over time? What might happen? How have other patients with your genetic condition fared? It may present the end of the diagnostic odyssey for patients who've been struggling their whole life, not knowing exactly what's going on and what's wrong. And it also provides us the opportunity to do genetic counseling, to test other individuals within a family who might also be affected, and implement treatment if needed for them as well. Okay, so here are the broad ways that we treat inborn errors of immunity. The first is cure. So sometimes we're able to offer a cure for an inborn error of immunity if the problem is with the bone marrow's production of the immune system, which in young children it often is. In that case, we can use treatments like a stem cell transplant. You take stem cells from a healthy donor with a healthy immune system, and you basically put it in that individual so that new immune system can grow and then produce a lifelong normal immune system for that patient. Other emerging therapies are gene editing, where you take the individual's stem cells out of their body, you do genetic manipulation to their stem cells to correct the problem, and then you reinfuse them back into the patient, and that actually cures the problem. There are targeted therapies, so if we know that a particular immune pathway is dysregulated or not working, then we can give immune system modification, so immune suppressant medications or immune modulating treatments. Some of these are biologic or injection treatments. In some cases, there's an enzyme deficiency where we can correct it with an infusion of enzymes. And then if there isn't a specific targeted therapy, or sometimes even when there is, we often give general supportive therapy to our patients. So that comes in the form of immune globulin replacement, which has a variety of different ways, as Dr. Kalasinski talked about. We give antimicrobials, antibiotics, antifungals, antivirals, depending on the specific issue. We often give our patients treat promptly cards. In other words, we let them know and let their physicians know that should they present with a fever or sign of sickness, they need to be treated right away rather than wait, as they don't have an immune system that's able to really promptly respond to an infection. Sometimes they get extra vaccines to help protect them, knowing that they may have a partial response. And then just making sure that the comprehensive health is addressed, whether it's nutrition, chest physiotherapy, or care from other specialists directed at whatever organs are involved with the immune system issue. Okay, so now I'm going to just, in the last few minutes, talk about the Canadian Inborn Errors of Immunity National Registry. So we know that Canada has a diverse population. We have rare and unique inborn errors of immunity. It's different than other countries. Some of you might be aware that there are patient registries in the United States, for example, UCIDNet, and in Europe through ECID, or the European Society for Immune Deficiencies, but our population is unique. We also know that in Canada, we have a unique profile of a publicly funded healthcare system. We also have lots of rural and remote areas, a population that's spread across a huge landmass. And most patients with inborn errors of immunity are treated at a small number of quaternary and tertiary care centers across the country. So we know that there's a need to learn more about our unique landscape of inborn errors of immunity. Studies looking at, what are we doing well, what are we not doing well in Canada for inborn errors of immunity, have found that, by and large, we have a lot of good things going on, but one of the weaknesses identified is our lack of a patient registry within Canada. And so in order to meet this need, over the last 3-4 years, a working group led by Dr. Del Falvey at Dalhousie and Dr. Nikki Wright in Calgary, along with working group members across the entire country, including locally at our center, have been working to establish a registry so that we can get more information about who are we treating with inborn errors of immunity, how are they being treated, what is going well, what is the quality of life like for patients with inborn errors of immunity. Okay, so how is the registry going to work? Well, individuals, patients that are pediatric patients, adult patients, as well as their caregivers who agree to participate in the registry will be getting an initial survey about some general details, as well as an annual survey about their medical history, their treatments, and their quality of life. And then de-identified information gets transmitted to a secure electronic database that is only linked with a confidential patient number, not to their name or identifying information, gets submitted to the central site, which is Calgary. And then physicians at the same time enter the more medical details of the patient's history. And again, the de-identified anonymized information gets transmitted to the registry. And ultimately, the main goal of the registry is to improve care for inborn errors of immunity within Canada, but more specifically to understand details about who has immune deficiency, how are they treated, are they happy with their treatment. It may also serve as a tool to train the next generation of immunologists in Canada who are going to learn how to do studies and research with the data. It will serve as an opportunity for rare disorders to maybe recruit patients for randomized trials to look at new treatments and new modalities for treatment. So it's going to be a very powerful tool. As part of our inborn errors of immunity, we're going to have patients' quality of life measures, including treatment satisfaction, adolescent to adult transition questionnaires, and hopefully also strong engagement from individuals affected by inborn errors of immunity across Canada. So what can you do to help? Well, we really hope that we can include all patients across the whole country with inborn errors of immunity. So once the study opens in Manitoba, which we're hoping will happen within the next 6 months, we hope you would all consider being part of the registry. And if you're interested in having a say in the registry, we also are working with a patient advocacy council to inform the registry steering committee and make sure that we're also addressing patient and parent needs that are unique to Manitoba and Saskatchewan. Okay, so just to highlight some other studies in addition to the registry that are recently completed or that are in progress within Manitoba. Some of you might have been part of or aware of the VISID study, which is looking at how individuals with inborn errors of immunity responded to COVID immunizations, and results of the study are about to be published soon, so stay tuned for results. Some of you may also have been involved with the ENGAGE study, which is looking at experiences of families and children who are immunocompromised during COVID and other future pandemics. There's a gene editing trial that will be opening up for individuals with a form of SCID that we see more in Manitoba called CD3 Delta. Our site is also a primary immune deficiency treatment consortium site where we look at treatment for individuals with SCID and chronic granulomatous disease or CGD, and that's an ongoing study. And then we're also looking at, as I mentioned with that CBC article, the burden of this rare genetic condition in Canada that predisposes to severe viral infections. Okay, so to conclude, inborn errors of immunity are actually more common than some individuals think, and way more common in Manitoba, we think also in Saskatchewan compared to elsewhere in North America, and maybe even elsewhere in Canada, but this is why we need the registry to learn more. Patients can be diagnosed at any age, from newborn to elderly. The treatment is multidisciplinary and comprehensive. It sometimes involves a cure, but also supportive therapy, and no matter what, lifelong monitoring. The evaluation includes both laboratory and genetics, and the National Registry is going to be a very powerful tool that we hope will be an ongoing effort to improve treatments and quality of life for individuals across Canada. Thank you.
What portion of immunodeficiency disorders can be treated with gene therapy?
Sure. Yeah. So the question was about the proportion of inborn errors of immunity or primary immune deficiency that could be treated with gene therapy. It's an excellent question. So right now, studies are focused on genetically diagnosed inborn errors of immunity, because in order to do gene therapies, you actually have to know what is the gene affected, and you have to be able to correct that defect in the gene. And it's been so far limited to sort of a few different categories, for example, SCID, chronic granulomatous disease. But as some of you might be aware, a lot of other diseases, not just in the inborn error of immunity sphere, are being increasingly addressed through gene therapies. And I think if you ask that question in 10 years, I might have a different answer. We're still in the early phases, but yes, I think this is one of the ways that we're going. There's a lot of advantages, of course, to gene editing, and it's a very promising, very exciting area, but I will say a tiny, tiny portion of the pie right now. Yeah.
Besides the time, when do you think we can develop a registry, national registry?
Right. So the National Registry, like the Manitoba site, has already received Research Ethics Board approval and conditional approval from the Health Authority. The site is already open and piloting in Calgary and Dalhousie. So we're really waiting for some legal things to go through in terms of data sharing across the different sites. But like I said, I think, I want to say within 3 to 6 months, the registry should open in Manitoba. So stay tuned, and it's happening soon. Yeah. Great. Oh.
I have had my immune deficiency all my life, but it only got diagnosed after my children were grown up and moved out. Can I have them tested?
That's a great question. So, oh yes, I'll repeat the question. So the question was about, in someone who has an immune deficiency diagnosed later in life, who has now adult children, could those adult children be tested? So the answer, like the short answer would be yes. It really depends on the specific circumstances. So there are different types of tests that you can do if there's a family history. One is like screening tests, like do your children have low IgG or low IgA? Have they made a good response to vaccines? They could be, those tests can be done, and they might be normal at one point in your life, but if someone starts to show symptoms later on, it may need to be retested. If someone has a known genetic diagnosis, depending on that specific gene and depending on knowing about whether or not that gene is passed on in a certain manner, we can have information about, is your child, do they have a 50% chance of being affected or close to 0% chance of being affected, depending on the genetic pattern of transmission. In that case, if you know a gene, you can specifically test your child to see if they inherited that gene. So screening tests for like just looking at your immune system are dynamic because it can change over time. Like perhaps someone who only got diagnosed in their 50s, if they were tested in their 20s, maybe things would have looked normal. So it's always worthwhile reconsidering things as someone gets older. We do know that some immune deficiencies, like common variable immune deficiency, can run in families. Not everyone is similarly affected. There can be a really wide range, but it can, these are genetic, even if we don't know the gene, or even if there's multiple genes at play and no one gene that makes the condition happen.
Thank you so much. Thank you, Dr.